Hi there. You walk into a home health visit and your patient says, I just don't feel right. The wound looks worse, and I've been running a low-grade fever. You assess them and something feels off. Now the question is, how do you document this so Medicare clearly sees skilled nursing is required? There's a unique framework here that I want you to not miss here, and it's condition leads to risk, which leads to skilled action, which leads to a response, and which leads to continued need. So the main point here is imagine a post-surgical or chronic wound patient in home health. During your visit, you find increased redness around the incision or the wound, new or increased drainage, foul odor or change in drainage characteristics, low-grade fever, slower than expected healing progress. Patient unsure if the symptoms are normal. Many nurses might just put wound appears infected, MD notified. But Medicare doesn't just want a label. They want a clinical story that shows skilled judgment and medical necessity. So there's a few steps here. Step number 1 is the condition. Ask yourself, what is the most significant clinical issue today? Well, in this case, possible wound infection, delayed healing complications, post-surgical or chronic wound instability, and systemic symptoms suggesting possible infection is progressing. This is not routine wound care. This is a complicated recovery with potential infection risk. Step number 2, the risk. Now I ask, what bad conditions could happen if this worsens? Well, this patient is at risk for localized infection progressing to cellulitis, sepsis, hospital readmission, wound dehiscence, and failure to heal. Functional decline due to systemic illness. Now the situation becomes of higher acuity because infection is not static. It escalates quickly if it's missed. Step number 3 is the skilled action. Ask yourself this. Why is a nurse required instead of a caregiver or self-care? Well, a caregiver can change a dressing. A nurse can assess wound progression and identify infection indicators, distinguish unexpected healing changes from complications, and evaluate systemic symptoms in context of wound status, and determine the urgency of provider notification, perform sterile wound care and reassessment, coordinate escalation of care when needed. This is skilled nursing judgment. Today's skilled actions may include full wound assessment with measurement and comparison to prior status, evaluation of drainage, odor, peri-wound condition, and healing progression, vital sign assessment for systemic infection indicators, and sterile dressing change per protocol, patient education on infection warning signs, and then to seek care, immediate physician notification of concerning changes. And then step 4, the response. What happens because of your interventions? Maybe the patient verbalizes understanding of infection warning signs. Caregiver agrees to monitor the temperature, wound changes more closely, or the physician provides updated treatment orders. Patient continues to show either worsening condition or unchanged symptoms. Document this very clearly. In infection cases, response may include escalation rather than improvement. That is still clinically valid. And then step 5, continued need. Ask yourself, why are future skilled nursing visits still necessary? Well, this patient continues to demonstrate active or suspected infection, delayed or complicated healing, need for ongoing wound and systemic monitoring, and high risk for rapid deterioration, need for continued coordination with the provider. That supports the continued skilled nursing services. So, putting it all together here. Now convert it into a clinical narrative. Patient with post-surgical wound noted to have increased heat in the skin, atheremia, moderate purulent drainage, and delayed healing compared to prior visit. Patient reports low-grade fever and generalized malaise. Skilled wound assessment performed, including measurement of wound dimensions, evaluation of drainage characteristics, peri-skin integrity, and assessment of systemic infection indicators. Sterile dressing change completed per protocol, and education provided regarding infection signs and symptoms, wound care precautions, and when to seek urgent medical attention. Physician notified of wound changes and systemic symptoms for further evaluation and potential treatment of modifications. Patient and caregiver verbalize understanding but continue to require enforcement regarding infection monitoring and wound management. Continued skilled nursing required due to suspected infection, delayed wound healing, and risk for systemic complications, including sepsis and rehospitalization. Medicare reviewer perspective on this is they look at the condition. Complicated wound healing with suspected infection. What's the risk? It's cellulitis, sepsis, hospitalization, wound failure. What is the skilled need? Clinical assessment, interpretation, infection recognition and coordination. The skilled intervention, wound care, monitoring, education, and escalation of care. And continued need. Well, the condition is unstable and requires close skilled oversight. So in closing, the next time you document an infection or complicated recovery case, don't just write, wound infected MD notified. Ask yourself these questions. What is the condition? What is the risk? Why was a nurse needed, and what skilled action occurred? Why are future visits still necessary? When you think this way, your documentation becomes more than just a task log. It becomes clear, defensible evidence of skilled nursing judgment in a high-risk home health situation. I hope this has been a benefit to you. If it has, consider subscribing. There's additional resources on the channel, and look forward to seeing you in the next one. Have a good day.